European Diploma in Anesthesia and Intensive Care, as well as the Fellowship of Royal College of Anesthesiologists, and he is specialized in regional anesthesia. And he has been a faculty at many regional anesthesia workshops in United Kingdom and at Mangalgiri and Guntur as well. He is active in many academic programs, and he is an associate editor of Journal of Anesthesia, Clinical Pharmacology and Indian Journal of Clinical Anesthesiology. He was awarded as an excellent reviewer from the Indian Journal of Clinical Anesthesiology in the year 2021, and also a Young Scientist Award for his contribution in the field of medicine in the year 2021. And he has been credited with his publications in the 51 national and international journals, and has also authored 4 chapters in various textbooks. And his areas of interest are regional anesthesiology. So over to you, sir, Dr. Ghanshyam.
Thank you very much. I'm just going to share my screen. Give me a second. Okay, so good evening, everyone. Firstly, from the outset, I would like to thank Dr. Bala Bhaskar, sir, Dr. Jyotsna, ISA Bellary City Branch for giving me this opportunity to present something in front of you people, though virtually. So before I proceed to discuss with the topic which I have selected, I'm just going to go through 2 case scenarios just to give you a taste of what we actually encounter in our day-to-day clinical practice, and then we'll talk about the topic in detail. So let's say you have got a 29-year-old Gravida 2 Para 1 patient who is coming to you with a history of pregnancy-induced hypertension and is posted for an emergency cesarean section, and she is at 36 weeks of gestation. And as her bloods, including the clotting, was normal, you have consented her for a spinal anesthesia, and you have performed the same in sitting position at L3, L4 interspace using a 25 gauge Quincke's needle. And at the end of clear CSF, you have injected the local anesthetic along with some adjuvant. Intraoperative period was uneventful, but the problem starts on day 1. So the day 1 post-op, the patient is now coming to you with a history of headache, stiff neck, nausea, and vomiting. So what do you think is the diagnosis? Though I wanted to make this presentation front to front so that we could have made it more informative and more engaging ones, but I'm happy for you people to put your comments on the chat box, and then at the end we can discuss these ones. So yes, as I'm going to talk on PDPS, that is one of the differential diagnoses, but what I want to make here a point here is that never ever jump on to make a diagnosis of PDPH unless you look into the history and then rule out the other important causes as well. So it could be a case of meningitis, it could be a case of PIH itself. There can be other differential diagnoses which we will talk later on. But here, as you can see, the risk factors are 36 weeks of gestation. Do you think pregnancy is a risk factor for the development of PDPH? And the second thing is use of a Quincke's needle. We will discuss that. But the story doesn't end there. On day 2 post-op, the patient is, you have prescribed her on regular paracetamol, some non-steroidals, weak opioid medications, antiemetics, and IV fluids. But neither the symptoms have got worsened, but they have not got better as well. So what is the plan of action is something we need to know. The second one scenario is, say for example, there is a 69-year-old female with a BMI of 41 who has underwent a right knee arthroscopy surgery under the spinal anesthesia. And this time you have used a dura separating needle, but as expected, it was a difficult spinal and it required a couple of attempts before you get a spinal in. Though it was a good block, intraoperative period was uneventful, but again, day 1 post-op, typical symptoms of PDPH is what the patient is presenting with to you. And day 2, by that time now she is completely bedridden. The patient doesn't want to get out of the bed as the headache is worsening. And to make the story more complicated, she is not willing for an epidural blood patch. You have consented her to have an epidural blood patch, but she is saying that you have taken so many attempts to get a spinal in. What is the guarantee that you will get an epidural on the first attempt? Which is a fair enough reason. Now the question arises is then how are we going to manage such cases when we come across in day-to-day activities? Okay, so I'm happy for you people to put again your views on the chat box. I'm sure most of you have come across cases of PDPH of different severity, but the question arises is, how do you diagnose PDPH? Is there a role for the management of conventional therapy? We all prescribe IV fluids. We ask the patient to drink coffee. We ask them to not to get out of the bed. But the question arises is, what we are doing is actually correct or not? Epidural blood patch, we all understand it is the gold standard treatment, but the question arises is, how effective is your epidural blood patch, and what is the ideal time to perform an epidural blood patch? Any one of you having a clinical experience of performing the epidural blood patch? If yes, it's fine. The other important question I would like to ask is, why few of us are so reluctant in doing the epidural blood patch when few of the patients, they actually warrant it? Then, if you do not want to perform an epidural blood patch, the last question will be, do we have any interventional or non-interventional modalities which are available in the management of PDPH? So that brings me to my present talk today. I'm going to just discuss about PDPH in brief and then take you through the recent updates which are available in the management of PDPH. So greetings from my institute, AIMS Mangalagiri, and I'm going to, in the allocated 30 minutes or so, I'm just going to stress on these topics. So to begin with, incidence. When we actually look into the literature, the incidence of PDPH, it varies widely from as low as 0.2% to as high as 3.6%, but it can be even higher. So why do we have such a range in the incidence? The reason being, when you go to the Western world, they follow up their patients very well for over a period of time. But in developing countries like India, it is a fact that we do not follow up our patients. So it may be a possibility that we may not come across many of the cases of PDPH who are suffering from mild to moderate severity, who did not require our attention. Probably we come across those cases who are like having a severe PDPH and then requiring our interventions. So that is the reason why the incidence varies. This is a very important thing. We need to understand how to define PDPH. Okay, so these are the criteria which are put forward by the ICHD. It is called as the International Society for Headache Disorders. And they have stressed upon 4 important points. And so the first point they say is that there has to be a history of dural puncture. That means whatever the headache the patient has developed is because there is either a low CSF pressure or there is a history of leakage of the CSF through the dural hole which we have created. Secondly, the patient has to present to you within 5 days of a history of dural puncture. Then you can call it as PDPH. Typical signs and symptoms, which we will go through in the next slide. What are the typical signs and symptoms? But a very last important statement, it is not better accounted by any other diagnosis. That means PDPH is a diagnosis of exclusion. You always look at the other important causes. That's what I was saying when we were discussing our first case. You do not jump on to making a diagnosis of PDPH. You look at what are the other possibilities the patient might be having, the causes of the headache, and then you come at a diagnosis of PDPH. So talking about the etiology, I'm sure most of you have read this, why PDPH happens. We all understand there is about 150 ml of CSF present in the body. 75 ml is present intracranially and 75 ml is present extracranially. So whenever there is a loss of CSF because of the dural hole which we have created, what happens, the lower part of the brain, it starts sagging. So whenever there is a traction on the baneful structures, including the meninges, dura mater, skin, and the cranial nerves, the patient will develop headache, which is going to radiate to the lower part of the neck and the shoulder area. The second important thing is there is a loss of CSF results in compensatory cerebral vasodilatation, because we know that according to the Monro-Kelly's principle, the volume of the skull has to remain constant. So whenever there is a loss of CSF, the brain is not going to get enlarged. So it comes at a cost of causing a cerebral vasodilatation. So the blood flow to the cranial cavity increases. But whenever there is a cerebral vasodilatation, there is occurrence of headache. And with the loss of CSF, we know that the effect of buoyancy is lost. That is why patient develops headache. So that is the pathophysiology behind the etiology behind the development of PDPH. But if you look into the literature, there are a few case reports wherein the patient actually had a low CSF pressure, but did not manifest with the signs and symptoms of PDPH. And not all patients who develop significant headache will not have low CSF pressure. So there will be variations as well. So I said there are typical signs and symptoms of PDPH. So these are the typical signs and symptoms. When you see a patient, you will never ever forget that in the life. So the patient usually presents with a dull throbbing type of headache, which is usually located in the bilateral frontal and the occipital area. And they typically have a postural variation. They say that when they sit up or when they stand, the headache is going to worsen. When they lie down, it usually gets resolved. That headache in the occipital area may migrate to the spinal, the lower cervical area and into the upper shoulder regions. They usually present with associated symptoms, be it diplopia, photophobia, tinnitus, vertigo, nausea, vomiting, which is usually not seen with other types of headaches, except for pneumocephalus, which also has got a postural variation. But otherwise, these are the typical signs and symptoms which you see in cases of a PDPH. So this is a very self-explanatory table, which is describing the severity of PDPH as mild, moderate, and severe, based upon whether the patient is able to perform the activities of daily living or not, whether the patient is able to get out of the bed or not, are there any associated symptoms with this, and whether the patient requires any treatment, and if the patient requires treatment, is the patient responding to your treatment? Accordingly, you can classify it as mild, moderate, and severe. And as I said earlier, it is only the moderate to severe type of PDPH patients which you actually see. That means majority of your patients suffering from PDPS, they recover on their own without any intervention. So you may not even come across like 60 to 70% of PDPH cases. It's only those who are not able to get out of the bed, they are not able to perform their activities of daily living, need your focus. So another important side for the postgraduates, what are the risk factors for the development of PDPH? You can classify that into patient risk factors and procedural risk factors. So patient risk factors include age. We all know that younger age is a risk factor for the development of PDPH compared to elderly patients. For unknown reasons, female patients are at higher risk of having a PDPH compared to males. And if they are pregnant, there is a higher chance that they will have a PDPH compared to non-pregnant patients. The reason being, yes, there is an increase in intra-abdominal pressure, which is going to increase your pressure within the CSF. And on top of that, during the process of labor, as the mother is participating in the experience of childbirth, because of the squeezing, there is increase in intracranial pressure, which will result in excessive CSF loss. How about BMI? We had a patient who had a BMI of 41 when we were discussing the second case. But remember, it is the low BMI which is said to be a risk factor, but high BMI is not a risk factor for the development of PDPH. And when it comes to smoking, smokers are at a higher risk of developing PDPH. Sorry, the non-smokers are at a higher risk of developing PDPH compared to the smokers. So those are the patient risk factors. Talking about the procedural risk factors, needle size and needle type. I'm sure all of you agree that if you are using a higher gauge of the needle, for example, a bigger size of the needle, say 21 gauge or 23 gauge, the incidence of PDPH is going to be higher compared to 25 gauge and 27 gauge. And there is a reasonable evidence available to prove that. But when it comes to the type of the needle, we can divide the types of the spinal needles into dura separating and dura cutting needles. And the theoretical, the teaching is that if you use a dura separating needles, the incidence of PDPH is less compared to the dura cutting needles. But I would like you to focus on the picture which I have taken from Mysora. We all were told that the fibers of these durameter, they are arranged parallel to the fibers of the longitudinal axis of the spinal cord. But when you look into this microscopy, you can understand that the fibers are arranged in all the possible directions. So whether you are using a dura separating needle or a dura cutting needle, actually, when you look into the well-organized randomized control trials, they didn't find much of a difference. I'm not saying not to use a dura separating needle over the dura cutting needle if it is available, but I'm talking in terms of evidence, there is not much of a difference in terms of the incidence. Again, bevel orientation, we know that dura separating needles do not have a bevel, so there is it becomes irrelevant. But when we are using a dura cutting needles, again, we were told that you insert the bevel parallel to the longitudinal axis of the spinal cord so that you do not cut the dura. But looking at this picture, again, it doesn't make a much of a difference whether you are inserting it perpendicular or parallel in terms of incidence of PDPH. But again, if you want to insert it parallel to this one, to the spine, it is fine because you can at least prevent a complication. Coming to the loss of resistance with the air or saline. So,
I'm sorry for the interruption. Please unmute once, please.
Am I audible now?
Yeah, enough, please.
Okay. Coming to the loss of resistance using the epidural needles. again, I mean, when you are doing the spinal, it's not a relevance. When you are doing the epidural, the question arises, should I use air to get the loss of resistance, or should I use a saline? It is not going to affect your outcome with PDPH, whether you use loss of resistance to air technique or saline technique. The incidence of PDPH doesn't differ. But as I said, pneumocephalus is one of the differential diagnoses, and that occurs when you are using the loss of resistance with air technique to get the epidural space. In my routine practice, I use saline because I find it even convenient. And I ask you people, why do you want to use air when we can equally use saline to get a loss of resistance technique, and potentially at least we can avoid one of the differential diagnoses, pneumocephalus, from happening. Coming to the other important things, reinsertion of a stellate. So few people say once you inject the local anesthetic, you reinsert your stellate and then take the spinal needle out, because the theoretical teaching is that there may be a possibility that one of the fibers of the dura mater may get strangled, and you may cause avulsion of it when you are taking the spinal needle out without reinserting the stellate. But again, there is not much of evidence for me to make any comment on this one. Patient positioning, whether you are doing the spinal with the patient in the lateral position or with the patient in the sitting position, does it make a difference? Again, there is an argument saying that if you are doing the spinal in the sitting position, because of increase in gravity, there is an increased loss of CSF compared to when you are doing in the lateral position. But the other concept is that when you are doing it in lateral, probably you require more than one attempts because the anatomy is not very well felt, and you can get the spinal done quickly in lesser number of attempts because the patient is in sitting position. But again, there is no quality evidence to say that which one should be preferred to decrease the incidence of PDPH. And then comes the number of attempts. As we were discussing in our second case, if you take 8 attempts or if you take single attempt, does it really make a difference in terms of incidence of PDPH? Theoretically, you could argue saying that if I take more attempts, probably the incidence of PDPH is higher. But again, there is no quality evidence suggesting that lesser number of the attempts means lesser incidence of PDPH. The last one is the weather. So this was the article, I mean, a clinical audit which was recently published, wherein the authors have looked into the effect of season, comparing the winter season with the summer season. And they have found that the incidence of PDPH is higher in the summer seasons compared to winter, because the dehydration is a side effect of, is a precipitating factor for PDPH. Another important slide, differential diagnosis. As I said, PDPH is a diagnosis of exclusion. So you have to look into these causes first to make sure that the patient is not having any of these as a cause of PDPH, which includes venous thrombosis, it could be infection, it could be pneumocephalus, it could be PIH itself in pregnancy patients. It could be very few important causes of headache, which includes migraine, tension headache, caffeine withdrawal, and etc. Or it could be intracranial space occupying lesions. The most important thing is the subarachnoid hemorrhage, which we have to rule out. So as I was stressing on the fact, PDPH is a diagnosis of exclusion. Okay, so you see the patient. If you think that the patient is presenting with typical signs and symptoms, which we have already described, patient is fitting into the diagnostic criteria, which we have already described, we have ruled out these causes, then probably you are dealing with what is called as a PDPH. Do you always ask for an investigation? The answer is no. You do not ask for any investigations to diagnose PDPH. MRI of the brain is only asked when you are in a dilemma, when you are not unsure of the diagnosis of PDPH, or you are not able to rule out the other important causes of PDPH, then you probably can ask for an MRI. Or say, for example, you have done a first epidural blood patch and the patient has come back with relapse of headache. And before taking a second epidural, you want to be sure that, okay, what I am dealing is actually PDPH. In that case, you can ask for a radiological imaging. So what are you going to expect on an MRI? You will see diffuse meningeal enhancement. You will also see cerebral vasodilation, which we have already discussed. There will be contracted ventricles because there is loss of CSF. You may also be able to see the presence of a dural hole in the dura mater and presence of the CSF outside the dura in the extradural space. These are the typical findings which you will see. So the next important topic which comes is the conservative management. So I'm sure when we come across a case of PDPH, this is the routine practice what we do. We ask the patient not to get out of the bed. We prescribe them some IV fluids with the hope that increase in IV fluids will increase the CSF production. We'll prescribe abdominal binders, we'll prescribe some stool softeners, we'll prescribe simple analgesics, including paracetamol, non-steroidals, weak opioid medications. And if required, we do prescribe some strong opioid medications. There are n number of drugs people have tried, including caffeine. If it is not available, as I said, we ask the patient to drink a couple of cups of coffee. Theophylline, sumatriptan, and n number of medications. But the question arises is, do we have a quality evidence to say that, okay, conventional management should be prescribed? Let me make it very, very clear here. There is no role for conventional management because there is a very weak supportive evidence available for the routine prescription of conventional management in the treatment of PDPH. Again, I am not saying not to do this. Yes, you definitely can prescribe conventional management, but it is not going to make much of a difference in terms of quality. The patient is not able to get out of the bed. The headache is still going to be persistent, though the severity might decrease. That is why you have to think out of the box. What else I can do in the management of these patients on top of conventional management? We all know that epidural blood patch is the gold standard management for the treatment of PDPH. We will talk about that one in the next slide. So these are the recommendations I have taken up from the Royal College of Anesthesiologists. What they are saying is bed rest is fine, but you are also increasing the risk of thromboembolism. So you have to keep that in mind. So as long as the patient thinks that they can get out of the bed, ask them not to lie down. If they want to get out of the bed, it's completely fine. You encourage the patients to take enough oral fluids. There is no indication to prescribe IV fluids unless the patient is having severe nausea and vomiting and they are getting dehydrated. They are not keeping anything down. They are vomiting it persistently. In that case, you can prescribe IV fluids, but otherwise there is no indication to prescribe IV fluids. Stronger opioids, you should usually avoid them because we all know that opioids will cause nausea and vomiting, and that vomiting is going to increase your intracranial pressure, resulting in excessive CSF loss. So it is better to avoid. As I said, epidural blood patch is the treatment of choice, but the criteria says that you delay it for at least 24 to 48 hours if it is possible. We will discuss that why. So there are 4 important things I would like to discuss here. The first thing is the effectiveness. How effective is your epidural blood patch? I remember when I was doing my post-graduation, we were told that the epidural blood patch is 90% effective when you do it for the first time. And the remaining 10% of the patients, if they come back with relapse of the headache, you do another second epidural blood patch, so 99% success rate. But if you look at this now, the effectiveness of first epidural blood patch is hardly 60 to 70%. That means in the past, we were not following our patients very well. We did a epidural blood patch. Next day, we asked the patient. She said she's completely fine. We didn't follow them up. If you follow them up over a period of time, maybe up to 14 days, you will come to know that majority of those patients are now having a relapse of the headache. So they are coming back for the second epidural. And the success rate of second epidural is around 70 to 80%. Optimum blood volume. So if you have decided for an epidural blood patch, the question arises is how much blood you should be injecting. There are n number of RCTs you can find in the literature wherein the authors have compared right from 5 ml up to 30 ml of the volume. But the large consensus is that around 20 ml is the optimum blood volume to inject. So whenever you are doing an epidural blood patch, there are 2 things the patient will complain of. Either they say that the symptoms have completely resolved all of a sudden because of the tamponade effect which we have created. So they feel a lot better. So that is the point to stop injecting. Or they will say that they are feeling fullness in the back. So that is an indication that you should stop no matter how much you have injected by that time. If they do not complain of either of these 2, then you inject about 20 ml of the blood and then you stop it. There is no point in going further more than 20 ml because you are only increasing the risk of complications rather than making the success rate to go up. The third thing is the level. Where should you inject the epidural blood patch? For example, probably you had a difficult epidural. So you will see that there are n number of attempts taken right from L1, L2 to L3, L4. So if you are not sure where actually you have encountered a dural puncture, in that case, you can either go at the lowest level or a space below where you can see that the puncture was taken. And if you are very, very sure that, okay, this was the point where the accidental dural puncture has occurred, in that case, you can go at the same level or a space below, because whatever the blood you are going to inject is going to spread the cephalad, and that is going to help you in sealing off this one. The last question, which is the most important question arises is, when should you perform an epidural blood patch? For example, the patient has come to you today and you have diagnosed it as a case of PDPH. The recommendations are to delay it for at least 1 to 2 days. Now, the reason why they are saying it not to perform on the day when you come across a case of PDPH is because the rate at which the CSF is getting lost through the dural hole which you have created, it is very, very high. So if you perform an epidural blood patch, whatever the clot which has been formed, with the flow of the CSF, there is a possibility that the clot will get displaced. So that is why the effectiveness of blood patch decreases. They may end up coming back to you for a second epidural blood patch. The second reason, few authors are of the opinion that there will be some inflammatory mediators circulating in the body post-surgery. So those inflammatory mediators may cause lysis of the blood. So if you have performed epidural blood patch within 24 to 48 hours, there is a possibility that whatever the clot you have formed, it will get lysed. That is why the effectiveness decreases. So if you can wait for 24 to 48 hours, then the chances of you performing the epidural blood patch, the success rate will increase. So we all again agree that epidural blood patch is not a straightforward procedure, isn't it? You need a little bit of experience. You need a setup. You need a sterile theater. You need a sterile kit. You need manpower. And it is not free of complications. I agree with that, because probably the reason why the patient is coming back with PDPH is because it was a difficult epidural. So there is a chance that you may not get a epidural place. So there is a failure. And worst thing is, what if you end up puncturing the dura for the second time? You are worsening the headache the patient is already having. There is a possibility of infection, nerve damage, and the epidural hematoma can result in paraplegia. So you have to consent the patient very well before you take up the epidural blood patch. So now you are in a tussle saying that, yes, conventional management is not going to help me because there is no literature evidence. You are not in favor of performing the epidural blood patch within 24 to 48 hours. So the question arises is, what should I be doing for a day or so? Should I just sit back, or I need to look into other modalities which are now available? So there are two modalities which I have divided into, depending upon whether it is a pharmacological one or the interventional modality. So read this statement. Forget the epidural blood patch. We have a medical option which works for PDPH. If this statement is actually becomes a reality in the near future, it will be a blessing for all of us. And the reason why I'm saying this is based upon the results of this randomized control trial, which was published in 2018 in Anesthesia Analgesia Journal from Ben Suef University by Abdilal Ahmad and colleagues. It's a very famous university in Egypt. And what they have done in this RCT is that they have performed elective cesarean sections using spinal anesthesia. Spinal was performed in sitting position using a 22 gauge Quincke needle. And those patients who developed PDPH in the postoperative period, they assessed their VAS score. Those patients who were having a severe headache with a VAS score of more than 5 were enrolled into this study. And the rest of the patients who were having PDPH, but if the VAS score was less than 5, were not enrolled into this study. Yes, they have used a 22 gauge Quincke needle, which is not a normal standard practice. But when you read the RCT, the authors have clearly mentioned that this is the best type and size of the needle available at their institute because of the cost and other logistical issues. And I think we should respect that. So what the authors have done, actually, they have divided the patients into a treatment group and a control group. And they have used two very simple drugs, which we normally use in our routine practice, administration of neostigmine and atropine in the treatment group. And they have compared that with the control group. So in the treatment group, what they have done is they have given 20 microgram per kg of neostigmine and 10 microgram per kg of atropine of the body weight. They have diluted these drugs by using a 20 ml of 0.9% normal saline. And these drugs were given as an infusion over a period of 5 minutes. So the time they have diagnosed it as a case of PDPH, in the treatment group, they have given these two drugs. And the plan was to repeat this infusion every 8 hourly up to a maximum of 72 hours if the VAS score of the patient remains more than 3. In the control group, they have just given normal saline if the VAS score was more than 3. In the treatment group, if the VAS score falls below 3, instead of giving the drug, the authors have given normal saline even in the treatment group for the purpose of blinding. And in the control group, as I said, normal saline was given every 8 hourly. And they have done this intervention up to 72 hours. And at the end of 72 hours, if the VAS score remains more than 5, or before the 72 hours intervention, if the parturient requests for an epidural blood patch, the authors would perform an epidural blood patch. The primary outcome for their study was the VAS score at the end of 24 hours of intervention. The secondary outcome they looked was what was the need for epidural blood patch, neck stiffness, nausea, and vomiting. I have not included the demographic table because the demographics were matching in both the groups. So look at the this one. So if you can look into both the groups, you can imagine the type of the headache these patients have. That is why I say, if you see a case of PDPH, you will never forget in your life how debilitating this feature is. So they were scoring a very high VAS score of 8 to 9 or 7 to 9, both in the groups. And once they did the intervention at 0 hours, when they followed up their patient at 6 hours, look at the difference the treatment group was having. The VAS score was dropped to 3 with a range of 2 to 4, but it remained quite high in the control group. And as I said, at the end of 8 hours, the plan was to repeat a dose of neostigmine and atropine if the VAS score was more than 3. As few of the patients had a VAS score of more than 3, they repeated the second dose at 8 hours. And after that, as you can see, none of the patients in the treatment group had a VAS score of more than 3, whereas the VAS score remained quite high in the control group at all point intervals. Coming to the incident, the need for an epidural blood patch, as you can see, none of the patient had a high VAS score, so nobody required an epidural blood patch in the treatment group compared to 7 patients who requested an epidural blood patch in the control group. But unfortunately, the authors didn't find any difference in terms of neck stiffness or nausea and vomiting, both in the treatment and the control group. So to summarize the results, I have already summarized the first two, that the VAS score was significantly better. None of the patients required an epidural blood patch in the treatment group, and no patients required more than 2 doses of neostigmine and atropine in the treatment group as well. So the question arises is how these two commonly used drugs are making a significant effect in the management of PDPH. I'm not going to go into the details because of the time limit, but I have just summarized how these two drugs are acting. So we all know that neostigmine is a quaternary acetylcholinesterase inhibitor. It doesn't cross your blood-brain barrier, but it can cross your blood CSF barrier. And once it crosses, it is going to increase the levels of acetylcholine by inhibiting the enzyme. This is typically what happens in organophosphorus poisoning compounds, isn't it? So there will be increase in the secretion. So the CSF production is going to increase. That is why it is going to help in the management of PDPH. Atropine is a tertiary anticholinergic compound. So it is a parasympathoinhibitic. So by acting on the sphenopalatine ganglion, which is a parasympathetic ganglion, it is going to cause a increased sympathetic activity. Sympathetic activity is going to cause cerebral vasoconstriction. So as we discussed in the etiology, cerebral vasodilatation is a cause for PDPH. So by causing cerebral vasoconstriction, it is going to take the headache away. So that was the pharmacological intervention. Coming to the other intervention treatments which we can do, epidural blood patch is something I have already discussed. These are the newer modalities we can look into. One is called as a greater occipital nerve block, and the second one is the sphenopalatine ganglion block. This is a beautiful article to read, wherein the authors have described whether we have found a new solution to an old problem which is persisting for decades and decades. Probably the answer is yes, but we need more randomized control trials in the near future. So I am beginning with the greater occipital nerve block. So greater occipital nerve is a branch from the cervical plexus arising from C2, C3 nerve roots, and it is going to supply your sensory innervation in the occipital area, and it also supplies the muscles in the back of the neck. The mechanism how greater occipital nerve block is going to take the headache away is that the nucleus of the trigeminal nerve is located in the brainstem, very, very close to the point where your greater occipital nerve is taking origin. So by blocking the greater occipital nerve, there is a chance that you are going to block the trigeminal nerve input as well, the nucleus of the trigeminal nerve. So when you do that blockade, the local anesthetic is going to inhibit the input, and as the sensory innervation from this area is via the trigeminal nerve, by blocking the input, you are making the headache to go away. So that is how it acts. In the olden days, landmark-based technique was commonly used. I'm not going to describe that because ultrasound has come up in a big way, how we are going to perform a greater occipital nerve block. So as you can see here, you are going to keep a linear probe over the external occipital protuberance here, and then you are going to scan the probe downwards until you see the first and second cervical vertebrae. And once you see the second cervical vertebrae, you are going to scan laterally to find the two muscles. So as you start your scanning from the greater from the external occipital protuberance, the first cervical vertebrae, which is the atlas vertebrae, is identified because this is the one vertebrae which doesn't have got a spinous process. And as you further scan down, you can see the bifid tubercles of the second cervical vertebrae, which is the axis vertebrae. So once you come to that point, you are just going to scan laterally, and you are going to keep the probe with the lateral end slightly cephaloid and the medial end slightly corded. So at that particular point, you are going to identify two important muscles. So the top muscle is called as semispinalis capitis, whereas the inferior muscle is called as the obliquus capitis inferior muscle. And exactly between these two, you will find your occipital nerve sandwiched between the two. And then you can do either an in-plane or out-of-plane block to block this nerve. The question arises is, do we have evidence? See, it is important to understand that the incidence of PDPH is very, very low. There are some other ethical issues involved when we are dealing with pregnant patients. That is why it actually becomes really difficult to do a large-scale randomized controlled trials. So whatever the evidence which is available is in the form of small-scale randomized controlled trials, case reports, and case series. I have read so many articles which are published on greater occipital nerve block, but all the articles are of the opinion that yes, it is a minimally invasive, simple procedure which can be performed on the patient's bedside with minimal complications, to which I agree. But the important advantage is that you can perform it within 48 hours. When you are waiting for your epidural blood patch, why not to give a good pain relief to the patient by performing either the pharmacological intervention or taking the greater occipital nerve block? And what is the ultimate aim? You are hoping that whatever the hole which we have created in the dura should seal off. So that may happen over a period of time. So if that happens, patient may not require an epidural blood patch. Or we have discussed our second case, if the patient doesn't want to have an epidural blood patch, you can at least offer these as an alternative treatment to such cases. Then talking about the sphenopalatine ganglion block, as I said, sphenopalatine ganglion is a parasympathetic ganglion, though there are some sympathetic fibers running through the ganglion. It is also called as a pterygopalatine ganglion or the Meckel's ganglion. It is present in your pterygopalatine fossa, exactly posterior to your middle turbinate. So once you do the blockade of this ganglion, there will be increased unopposed sympathetic activity, and the mechanism we have already discussed. So as you can see in these pictures, you can actually see that there is a pterygopalatine fossa, which is exactly present posterior to your middle turbinate. So you just need to take a swab stick, which is dipped in either a local anesthetic, 4% lignocaine viscous is most commonly used, and you pass the stick parallel to the floor of the neck, nose until you feel a resistance. That is the point where you are probably hitting the pterygopalatine fossa, and you leave the swab in place for about 10 to 15 minutes, and you have to repeat the procedure on the other side. So this is a bilateral transnasal approach for the sphenopalatine ganglion block. Though there are other approaches, I am not going to discuss. For example, transsphenoidal approach, people have used radio frequency, but these procedures are commonly done by our pain physicians. So similar to greater occipital nerve, it is a minimally invasive bedside procedure, and you can offer it as an alternative to epidural blood patch with minimal complications. And but the problem is we do not have a quality evidence to suggest whether epidural blood patch should be the gold standard over these procedures, and whether greater occipital nerve compared to sphenopalatine ganglion, which one is superior. There is not much of a literature, so we need to look into the further trials what comes out. The last one is the surgical repair of the dura mater. Understandably, it is reserved as a last resort, and I didn't find any case series or RCTs on this one. There are few case reports where you can see that, okay, the patient didn't respond to 2 or 3 epidural blood patch, and they had taken up the patient for surgical repair of the dura mater. But there is very limited literature making me unable to comment anything on this one. This is the last modality which I have come across, which is called as Saker's dish-10 maneuver. It was recently published in British Journal of Anesthesiology. So dish basically stands for deep inspiration, squeeze, and hold for 10 seconds. So here you are asking the patient to lie down with feet elevated, and you are asking the patient to take a deep inspiration and then squeeze both the chest and abdomen and hold the breath for about 10 seconds. And the patient has to repeat this maneuver every 6 minutes. So the patient has to repeat this 10 times per hour for a period of 5 hours. So in total, the patient has to do 50 maneuvers. So by doing that, the patient is increasing the intrathoracic and intra-abdominal pressure, which is going to cause engorgement of the epidural veins by creating a tamponade effect, which is helping your CSF flow to decrease by increasing the intracranial pressure. It will help for the headache to go away. So I'm coming towards the end of my presentation. So where we are standing. So if you think that a subset of our patients still require cesarean sections to get the babies out in the near future, we still need to do spinal anesthesia for them. So that means PDPH is not going to go anywhere, though the incidence might come out in the near future. So people are looking at different scopes. So they are looking at a fluoroscopy guided epidural blood patch. So they exactly want to see where the dural hole is, and they want to put the blood exactly at the site. Instead of blood, people are also putting fibrin glue, dextran 40, gelatin to see how they work out. A very interesting research question for all of us. Whether we can use a pre-procedure scanning. If we can have an ultrasound machine on the bedside, why can't we use it pre-procedure, and we can scan and then see at what depth the epidural space is lying, so that we can provide accidental dural puncture, and then whether it is going to help us in decreasing the incidence of PDPH is something the future trials will be looking at. And the last important thing is, say for example, you have come across a case of PDPH, you have prescribed conventional management, the patient hasn't got better. Can we leave them like that? Whether they are going to end up having a chronic headache and backache is the question arises. So this is the article in which I also co-authored, wherein we looked at whether there is any association between PDPH and the chronic headache and backache. Unfortunately, the answer is yes. If you do not manage your patients very well, and if you leave them on their own, on their destiny, more than 30% of their patients will end up having chronic headache and backache. So that is the reason why you have to act very promptly. And this raises a question of saying that PDPH is a self-limiting condition. Probably it is not so, and it raises the possibilities on financial and medical legal issues as well. So to summarize my talk, remember, majority of your patients with PDPS, they present within 72 hours. The criteria were saying the patient has to present within 5 days, but there are very few case reports wherein the patient actually presented with headache like 2 weeks later on. And when you actually investigated them, including MRI, you found that the cause of PDPH, it was actually a case of PDPH because there was a dural hole. So time limit is probably something we have to look into the future. PDPH, as I said, is a diagnosis of exclusion. You make sure that you rule out most important causes of this. Prophylactic intervention has got a very, very weak supportive evidence. So you always look into the other modalities, which we have already discussed. And if possible, delay performing the epidural blood patch in the first 24 to 48 hours. So in those 24 to 48 hours, you look for the newer strategies, which I have discussed. Either you want to go for opt for a medical management, which is fine, with the option is yours. Or if you want to perform greater occipital nerve block, sphenopalatine ganglion block, that is perfectly fine. So these modalities are acting as a bridging therapy in those 24 to 48 hours. And it is a possibility that the patient will get completely better by the end of day 2 and may not require epidural blood patch, or at least you can provide a good pain relief, and then you can consent for a epidural blood patch if the headache hasn't gone away, and you can take the performing the epidural blood patch at the end of 2 days. But the bottom line still remains is that the treatment of choice for the management of PDPH remains the epidural blood patch. Whatever the modalities I have discussed so far, either they are going to increase the CSF production or they are causing the cerebral vasoconstriction, but no one is treating at the cause except for the epidural blood patch. We know that the cause is there is a hole in the dura, you have to seal it off. So it is only the epidural blood patch which is going to do that. That is why it is still considered as a gold standard treatment. And the bottom line is very, very important. Why are we reluctant in performing the epidural blood patch? It is just another epidural injection. Instead of injecting the local anesthetic, we have to inject the patient's own blood. So do not be reluctant in performing one if the patient actually warrants it. So whatever I have said so far in the past 30 minutes or so, if it actually becomes a reality in the near future, say for example, the pharmacological intervention is going to act very well, or say for example, the newer modalities which we have discussed are going to prevent the requirement of epidural blood patch, probably we will have some liberty in the way we actually perform epidural blood patch, or we can allow our younger generation colleagues to come up with some fancy ideas, as this person has come up with some fancy ideas for performing the epidural blood patch, and take it from there in the near future. But future RCTs are going to throw up more light on how we should approach the cases of PDPH. So with that, I would like to thank once again all of you for your patient listening. That's the institute where I work, which is beautifully situated in the middle of the hills. And thank you so much for your patient listening. I'm more than happy to take up questions if there are any. Thank you so much.
Sure. Very beautiful presentation, Dr. Ghanshyam.
Thank you so much.
That beautiful location of AIIMS Mangalagiri also.
Thank you, sir.
So nice and
yes,
very comprehensive, at the same time very informative for the postgraduates also. So we've got certain questions in the chat box. Then as we go on, probably we can also invite more people to participate.
Sure.
So of course, Bharat Paliwal is there, our own colleague. You are there, Dr. Bharat?
Oh, yes, sir.
Yeah, sir, good evening, sir.
Yeah, you can.
Sir, good evening.
Yeah, you can unmute and you can speak also. Put the query to Dr. Ghanshyam directly.
First of all, Ghanshyam, very excellent presentation.
Thank you,
It's
sir.
always good to listen you. So just you were discussing why to use air instead of saline. So my personal reason for using saline is that I better appreciate a recoil. So that is the reason. The only precaution I take care is once I do not inject the entire air into the epidural space to confirm it. Just it's the recoil, the loss of recoil gives me an appreciation that I had reached an epidural space. I confirm it by putting a saline after that. So I perceive recoil better with air, so I still go with the air. And to avoid patchy epidural, I avoid injecting, or a headache from pneumocephalus, I avoid it. So that is my reason for using air. And second thing is, just I wanted to clarify the definition of post-dural puncture headache. So we said that it increases with the number of attempts. So do by number of attempts we means at every incidence we puncture the dura, or it's the number of skin punctures which we go ahead and we count it as number of attempts. So please clarify on that.
No, the number of attempts is the number of attempts you have punctured the skin, not the dura. But there might be a possibility that what happens when we are using the small gauge needles, or when we are performing the spinals in the lateral position, there may not be enough CSF flow. Or sometimes it is a possibility that the tip of the needle has actually entered, but there is no CSF flow. So it is actually, you are not sure whether you have punctured the dura or not. So the RCTs which you have taken the number of attempts, they have taken the number of attempts at the skin level, not with the dura. So, but the other thing is that there is no evidence. That's what I said. Whether you take 8 number of attempts or 1 number of attempts, the incidence of PDPS didn't differ in the RCTs. That is what it is.
Thank you. Thank you.
Thanks a lot, Dr. Baliva. And Dr. Lalit Kumar Raigar, sir, I asked, of course, this is an academic discussion, and whether PGs would also want to know among the alternative options, whether TENS has got any role. TENS for PDPH. Dr. Ghanshyam?
TENS, I have not come across any articles suggesting. I have come across erector spinae plane blocks rather than the TENS therapy in the management of PDPH.
Yeah.
Neither I have come across this one, but I don't think there is any quality evidence. If people are using it, that is fine, but there is no quality evidence to support the use of TENS therapy in the management of PDPH. Definitely, certainly not. Yes.
So there could be some monitor. Yes, sir. Please, sir, go ahead.
Yes, sir. Previously, when we are not having these pharmacological drugs in periphery, also where TNS machine is available, that give relief to patients when we applied temporarily.
Okay.
So that's why I asking, when somebody, colleagues who are working in periphery, they are asking and they are giving. When there is nothing they are not able to do, they are doing with TNS or caffeine or plenty of fluids like that.
I mean, I have no personal experience on this one, but in the literature, there is no evidence. That's what I was saying. Probably it is going to work, but there is no RCTs or something which I have come across on the use of
Yeah.
it.
When we don't have too many options, again, our practitioners would like to have something which they can offer, and maybe it would work in some cases. So
Yes,
it's possible. It's possible. Yeah. And of course, some basic questions. You can just answer them. Dr. Sadiq Mohammed is asking, there are case reports of unuse of epidural saline infusion for patients with PDPH. What's your take on it?
Whether you use epidural saline, I mean, I haven't touched on what is called as a prophylactic epidural blood patch as well, or something called as threading the catheter once you actually come across accidental dural puncture. People have used it, but the question is, yes, it is going to provide the tamponade effect. That is fine. So saline, if you administer into the epidural space, this is going to provide the tamponade effect. But ultimately, what you want is that saline to stay at the site where you have created the dural hole. Is that going to stay? Probably not, because that saline is going to disappear over a period of time. The epidural clot is going to stay at that point, and it is going to wait until the dural fibers will get healed. So that is the reason why the epidural blood patch is superior compared to the saline. But yes, saline can be administered when the patient, for example, you come across a Jehovah's Witness or somebody who do not want to have their own blood also injected. That is the option which we have. But the effectiveness will be very, very less, because once the saline gets disappeared from the hole, the CSF will again start leaking from there.
So related to the previous suggestion by Dr. Bharat and this current question. So technically, I just found some discussion in the literature that if there is this puncture and you have used saline to go inside to enter the epidural space, so there is a CSF leak and there is also possibly some saline. So there is discussion about whether this would affect the effective patch by the blood, which is deposited in the epidural space. Does it interfere with an effective fibrosis or clotting of the blood when you place an epidural blood patch?
I'm not sure about it, so whether it is actually going to make the effect, but probably, I mean, you are thinking in terms of whether the clot will get diluted and it may not form as effective as you would encounter, but I'm not able to comment on anything on this. I haven't read something like this.
No, there is one of the evidences. That's the reason I asked. Like, as you said, so our basic knowledge, you would say that no, if there is a continuous CSF leak or there is some amount of saline and you push the blood, maybe it wouldn't allow the clot to form. But actually, they have suggested to the contrary. They said it actually helped in earlier clot formation, supporting some scientific background. So basically, that's why I just wanted to share with you. Overall, that particular study showed that there was earlier clotting with respect to CSF, but it was basically in vitro test.
Okay.
Sorry, definitely not in vivo. It was in vitro test, and they could find this evidence in that part, basically. Nice question. WA, I don't know who. The naming is not there. Is PDPH a misnomer? Shouldn't we call it PAPH?
Okay. People are now calling it as post-meningeal puncture headache. There are so many terminologies. Yes, questions have been raised whether it is actually a dural puncture headache. Not. But the thing is, many of us are actually used to the term PDPS. That is why people do not want to change that word. Yes, the terminology is probably not the right one, but that is the reason why everyone is used to that diagnosis of PDPH. That is why it is still persisting. Yes.
Actually, to the PDS also, I would like to say, because when we talk about the layers, it's dura matter, pia matter, and arachnoid matter. So they should simply understand that they are so much closely approximated, the dura matter and the pia matter. So you just pierce to dura matter, you're already in the subarachnoid space, basically. So that's one thing which they should theoretically remember.
Sure.
So as you say, it is basically post-dural puncture means it should not mean it is just simple subdural. It is straight away gone to the subarachnoid space.
Sure.
Then we have ACTH. One of our colleagues have asked about the basic role of ACTH. How does it help?
Role of?
Administer ACTH.
Okay. There is no quality evidence available. As I said, whether it is ACTH, sumatriptan, you can talk about colcintropin and all that.
Yeah.
When you actually see, and for any treatment to be effective, you have to do a RCT and then find out whether it's actually making any difference in the terms of it. When there is no quality evidence, it is very difficult to suggest on the management. There are a number of drugs which we have tried, but there is no quality evidence available.
Yeah, so many drugs have been used. Yes. And you got Dr. Shayak Roy, you are there? Should we include?
Yes,
you are there?
Yes, sir. Yes, sir.
Yeah, you can put the question to Dr. Sancham.
Sir, excellent presentation, sir. Sir, I want to know that is there any role of putting the spinal patient in the APS round? Should we include them or we should not to detect the PDPH?
Say that
Will it be
again.
beneficial?
Should we put what?
These patients in the APS round, should we follow them up?
APS is what?
Sir, acute pain service round.
Okay. See, in the Western world, when I was working at the UK, all the patients who have a spinal or epidurals are followed up by the team. So yes, every 24 hours, you have to go and see the patients until they get discharged from the hospital. So I strongly agree. That is why, as I said, we do not follow up our patients very well. So unless you follow up your patients, you will not come to know what is actually happening. So definitely acute pain team should definitely go ahead and then, see these patients on daily basis and then see what other problems they are having. It's not just the PDPH. You may have for numby patches, temporary nerve damage. These are all the possible complications. So unless you see these patients, how are you going to come up with what is actually happening? So it is strongly recommended.
Sir, in my current institute and previous institute also, we used to give more emphasis on the epidural rather than the spinal. That's what I was asking, that because of the sheer volume of the patients, do you think will it be beneficial?
Doing epidurals?
No, to find, to include the spinal other than the epidural.
What is your question?
My question is that because of the sheer volume of the quantity of the work, we usually follow up the epidural cases
Sure.
because chances of complications are more. Do you think will it be beneficial to follow in India the spinal cases?
Of course, we should. That is the standard treatment. We cannot say that the volume is too high. We are not able in a position to follow up the patients who had a spinal, and we will only follow up the epidural patients. No, definitely not. We should definitely follow the patients who have having a spinal as well. Of course, the incidence of PDPH is going to be less, but it is important to follow them up. Yes.
Okay. Thank you, sir.
Yeah, in one of the things which is discussed widely in different fora is majority of our practitioners, and we say that the incidence is actually less in India compared to Western population. But as you say, this is mainly because we are not following up.
Exactly. Why do you think that there is no race difference? So
yeah,
even in India, yes, of course.
It's simple that we are probably overworked, and as Dr. Shaikh has told, we have not been able to follow up. If you sincerely follow, probably the incidence is also more.
Majority of mild PDPH you will be able to detect, though they will not require any intervention from our side, but you will detect the.
We can just detect it.
Thank you, sir. Thank you,
and
sir.
I think too many people are asking about this epidural saline to me. See, the point I would like to make here very clear is that there are two things. One, for example, we are performing the epidural, and if you actually accidentally puncture the dura, what should we do? Should we thread the catheter inside, or should we just take the epidural needle out and then attempt it at the second one? There is no quality evidence to say that if you take the epidural needle out and then perform the epidural at a second space, the incidence of PDPH is going to be higher. It depends upon what type of patient you are dealing with. If you are probably doing an epidural in a high BMI patient and you think that the subsequent attempts are also going to be difficult, in that case, probably it is the best idea to thread your catheter and then use it as a continuous intrathecal technique. But if you think that probably a junior colleague has performed, I should be able to get an epidural in the second attempt. Most of the anesthetists which I have seen is that they take out the epidural needle and then they resite the epidural at a second space, and then they run the continuous infusion with the hope that they will be able to create a tamponade effect. Though, yes, the incidence of PDPH with accidental dural puncture is very, very high. It's 90%. So if you have performed a epidural for a labor analgesia, and if the patient was moving at the time because of the pain, and if you accidentally dural puncture is happening, yes, there is a high chances that the patient will have a PDPH. You want to thread the catheter and you want to keep it for 24 hours with the hope that there will be some fibrous tissue formed. And then the people say you inject some normal saline before you take out the catheter. But again, the question arises is, do we have a quality evidence? There is no quality evidence to suggest all this stuff. So I'm not able to make any firm comment on those things.
So, a basic question by Dr. Parimala. Any preventive measures on, actually you have discussed it already. You can just.
There is no role for epidural blood patch prophylactically. For example, you have done a accidental dural puncture and then you have cited the epidural in the next phase. Before taking out the catheter, should you inject the patient's blood? Definitely not, because you never know whether the patient is going to have PDPH or not. So why do you want to subject the patient to another risk of injecting the blood without coming to know? So there is no role for prophylactic interventions.
So Dr. Sadiq has asked, but any difference between epidural and intrathecal saline infusion for management of PDPH? I don't think we can directly, it's not, no question of intrathecal saline infusion per se. Is it there, Dr.? I don't.
I mean, yes, if you want to maintain the CSF volume, that is fine. But there are case reports wherein they were questioning, if you are increasing again the pressure within the CSF, is it not going to increase the CSF flow through the dura which we have created? Yeah. So, I mean, it is very difficult to comment on such things. Yes.
Yeah.
But just to add to it, our institute had a study where an epidural saline infusion was maintained to treat the PDPH. So it is published, and probably Dr. Sadiq has
yes, infusion is going to help because you want to maintain that constant pressure in the epidural space. A single injection of epidural saline is not going to help us. That is what I meant to. Probably yes, you can do an infusion of epidural infusion.
So
I have put that question. Hello.
Yes.
Hi, Ghanshyam.
Hi.
It's always very refreshing to hear you. Actually.
Thank you.
So actually, I have put this question to just let you know that in your next presentation, you can include this this treatment modality in your presentation, so that the audience came to know that yes, this is also an possible modality for the treatment
of epidural saline. I agree, not a single shot one. Yes.
Yeah, infusion is actually infusion.
That's good.
That's right.
Thank you.
Thank you. Thank you. And Dr. Purnima Vijaykumar has asked a basic question. How does the sphenopalatine ganglion block help?
Thank you for asking that question. Actually, if you look into the articles, as I said, 4% lignocaine viscous is a very commonly used one. But there is a recent article published in BJA in which the authors have compared ropivacaine with normal saline. And interestingly, they have found lesser incidence of headache in both the groups. So they have made a conclusion that it is the stimulation of the ganglion what is required. Yes, the duration was longer in the local anesthetic group because the local anesthetic acted for 12 to 24 hours. But even in the normal saline group, the incidence of the headache has decreased after the sphenopalatine ganglion block. And I think the question is whether we can repeat this procedure. Yes, you can repeat this procedure after 24 hours if the headache has come back again. So as long as the local anesthetic acts, it's fine. And once the local anesthetic stops wearing, the headache is going to come back. Probably that is a chance. In that case, you can repeat both the greater occipital nerve block as well as sphenopalatine ganglion block.
Okay. So a simple question. Our gynecologists usually give tablet Dolopar or dose 650 initially, and if they do not get relief only, they will call us for help. They're really helpful. Are they really helpful initially?
So as I said, conventional management has got a very weak evidence. I'm not saying not to prescribe. Yes, because the patient has had a surgery as well. So you have to look after that pain. So paracetamol is fine. And it is going to help the severity of the PDPH a little bit, but it's not going to make much of a difference.
Okay. So I don't think the chat box, not other questions are there.
Sir, good evening, sir. Dr. Bala Bhaskar, sir. Subramaniam from Anantapur, sir.
Yes, sir. Good evening, sir. Welcome, sir.
How are you, sir? Fine.
Yes, sir. Fine, sir.
And Dr. Ganesham, sir, it was really an excellent presentation. You have covered from basics to the latest advancement modalities of PDPH. And my simple doubt is whether I want to share your experience of using neostigmine and atropine, sir, for PDPH.
So far, I have treated 4 patients, 2 in the UK and 2 here. And I had a very satisfactory results with all the 4 patients. None of the patients required an epidural blood pass later on. In 1 patient, we had to give the second dose, but in the rest 3 patients, just 1 single dose of neostigmine and atropine had made a significant effect. They never had the second headache coming back. So probably the dural hole was sealed off, but all these patients were spinal patients. None of the patient I had an epidural. So I'm not able to comment whether it is going to make a difference when the hole is too big, because with these holes, probably we were expecting the dural hole to seal off. But neostigmine and atropine definitely helped in the severity of the management of PDPH for 24 to 48 hours. And after that, there was no relapse of the headache. So very satisfactory results for me so far.
But of course,
we usually follow
adverse effects there. No, that potential adverse effects are boring.
So even in that RCT, they have looked at bradycardia, nausea, vomiting, bronchospasm, which are the usual side effects of neostigmine. But the authors have clearly mentioned that, yes, you need to have all the equipments which are required for emergency management, but none of the patient had any life-threatening complications. So they may have complained a bit of nausea when the infusion is running out. But even with me, I never had any patient requiring any other interventions. They were very, very well tolerable side effects.
So that infusion for over 5 minutes, we have to give thrice in a day, sir?
Every 8th hourly, if the VAS score still remains more than 3, that was their criteria. So if the headache is not there, then there is no question of repeating it. But you can repeat it whenever required after 8 hours.
Because usually PDPH we see usually in VIP patients more commonly, sir, rather than the normal routine patients. That will be a very factor for us.
But this is something which you can definitely offer now. Yes.
Okay. Thank you, sir.
Thank you.
So any other questions? Actually, let me go back in time a little bit, or probably we are still into it. We had the COVID season. So in the last 1 to 2 years. So why I'm trying to stress upon it is even 2 days ago, we had a patient referred who went bad, apparently because of probably anaphylaxis to a drug. So post-cesarean section. So for post-cesarean section, and there was a history of anaphylaxis previously also. And pre-operatively, some drug was administered the previous night, and the patient went into anaphylaxis. The next day morning, for obstetric indications, when the so-called anaphylactic reaction had come down, it was taken up as an emergency. Post-operatively, post-procedure, basically, patient went down. So then the patient was shifted to the ICU. At that moment, when COVID screening was done, RAT was positive, rapid antigen test. So that's the reason it made, I'm mentioning it. So one of the technical aspects with relation to COVID is putting a blood patch, basically. So there is, I think, theoretical considerations related to seeding of the infection towards the brain. That's one of the things which has been discussed. So if you put a blood patch, autologous blood patch, and brain is so far free, so there is no infection in the brain in that particular patient. And if you do an autologous blood patch, there is theoretically a risk of creating this infection within the brain. So that is one of the things that has been discussed. And mainly also because, of course, the severity of COVID and symptom-wise, it has come down. But all said and done, it is advisable to go ahead with regional anesthesia. So we would want to avoid aerosolization and general anesthesia. So that way speaking, I think the risk still persists because we have to protect ourselves. That's always there. And another thing is we should also remember about the hypercoagulable state in COVID-19. So, and the patient would be on some low molecular heparin, or patient could be on simple aspirin or whatever, or even the standard heparin. So these are the things I think we should keep in mind when we talk about COVID-19 patients per se, and the risk of PDPH. So this is just, it came to my mind because we had a case just day before yesterday. And of course, luckily the patient survived also. That's the one thing I wanted to convey to all our colleagues. Because positivity is not going to come down. We may still become positive also after exposure despite vaccination. But symptom-wise, definitely patients are doing better. So any other question from our colleagues?
Bhaskar sir, no questions, but just I wanted to say it's always a nostalgic feeling when I hear of Vims Bellary. So I passed in 2004, and sir, as by your means, I just want to convey gratitudes to all my seniors over there, and say hi to all colleagues.
Oh, so nice to hear. Okay, yeah. So nice. So we will hope to have your presence sometime as a presenter.
Sir,
it should be very early.
Definitely, sir, and probably I may see you personally there in month of December when we will have a alumni meet there at Bellary.
You are there, huh? So nice. Sir.
Yes, sir. Yeah, thank you, sir.
Jyotsna?
Yes, sir.
So I think you can take over as chief organizer.
Thank you, sir. Thank you for an excellent presentation, quite informative. And as I said, it is very common but distressing for the patient as well as the anesthesiologist. And I think today we had one of the highest number of audience, like touched around 100. And thank you, sir, and for that lovely presentation. And we shall look forward to having you again as one of our speakers for your regional anesthesia.
Of course, but not virtually. I would like to
sure, sir. Thank you, sir.
Thank you so much.
So we have got direct train from Guntur to my place. we'll look forward to that.
Of course, sir. Right. Sure, sir. Thank you so much for that.
Thank you very much. Thank you.
Thank you, sir.
Thank
Good
you.
night, everybody.
Good night.
Good night. Thank you.
Thank you, sir.
Thank you.
And thanks to the audience as well.
Yeah.